All right, we're back live tonight. You're in Focus. The Health Department has revealed that one person has died from the monkeypox virus in South Africa. 5 cases in total have been recorded in parts of the country. 3 in KwaZulu-Natal, 2 in Gauteng, and one of those deaths is the one that has been, of course, reported here in Gauteng. Health Minister Dr Joe Phaahla joins us now for more on that. Minister, good evening, and thank you very much for your time.
Oh, evening, Tabo, and evening to your viewers. Thanks for having me on your show.
2 cases are 2 cases too many, but the requirement is that when that happens, or over 2 cases, you declare an outbreak. What's the classification of this outbreak?
Well, it is regarded by the World Health Organization as an outbreak when you have cases of an infectious disease like this one, which in a country which is not endemic. In other words, there are countries which for various diseases, whether it's malaria, whether it's cholera, and also Mpox, which are regarded as endemic. So South Africa is not one of those. So when you have an outbreak, and especially once you can confirm that it is not an imported case, but it's got features of a local transmission, then it is regarded as an outbreak. Just a small addition to say, following our press conference this afternoon, just about 1.5 hours later, we were actually updated that there's actually a 6th case. I'll say more about that.
Is it the West Africa clade strain that we are talking about, or the Central Africa clade strain? I believe this is how they are identified, one less severe than the other?
This is, in terms of genomic sequencing, is classified as clade 2B. Clade 2B, which is, the strain which is prevalent in what the WHO describes as the world outbreak strain. It's a strain which is found in various parts of the world, in the Americas, in Europe, and various parts of the continent. But it's different from the strain which is found in the DRC, which is called clade 1. I think the clade 1B is not clade 2. So that's the difference. But this one is the dominant one in the rest of the world.
So is that what makes it a little bit more severe? You're saying particularly to babies and pregnant women that could lead to severe sickness and possibly death. What is the case fatality ratio of this strain?
I must say at the case fatality ratio, I don't have the actual figure, but just looking at where we are currently. In the previous outbreak, which we had in 2022, we didn't have any fatalities. Ordinarily, in people who are not immune compromised, I know that the fatality rate is quite low. I just don't have the figure on my fingertips. But in immunocompromised individuals, and which explains also why, or just out of 5, when we had our press conference earlier on, we had 1 fatality. Now, there's something which we're still investigating on the 6th case, because by the time we were informed that there is another laboratory confirmed in Pietermaritzburg, the patient had already died this afternoon. And it took quite some time. It's something which I've asked our officials to follow up. He was admitted in a private hospital in Pietermaritzburg. It's quite it's something we need to check clinically, because the patient had been admitted almost 20 days ago in high care with symptoms and signs which were consistent. I don't know whether it was just a poor index of suspicion that the test was only, the Mpox was only confirmed this morning. In fact, almost like just after the patient had demised. So it's quite a worry. But even that particular patient, like the other 5, was also immunocompromised.
Yeah. So for accurate reporting then, Minister, shall we say now 6 cases, 2 deaths? Is that what you're telling us?
That's correct. That's correct. Just after our press conference, we then got this report of a laboratory confirmed case. And also when they describe how the patient presented is consistent with the symptoms and presentation sites of Mpox. I think it just took long for the doctors there maybe to send the sample to one of the private laboratories and confirm the diagnosis. So as things stand, we are correcting the numbers that it's actually 6 and with 2 deaths, which reflects a very high fatality rate, which in terms of, almost like 1/3 of the patients, 1/3 fatality, almost about 33%. So which is quite high, but all of them, including this last one, was also immunocompromised with HIV, which suggests that the patient was not taking treatment properly because the CD4 count, which reflects immunity, was very low.
So let's talk then about this. I don't know that it's too early to talk about it. 4 KZN cases, 2 Gauteng cases. Does that reflect where the epicenter could be, or is it too early to talk about epicenter right now?
It reflects the 2 provinces. Quite interestingly, Tabo and the viewers, that the patient who demised at Tembisa Hospital, his primary resident in terms of, people are very mobile in our country because of opportunities, work opportunities. The patient who demised at Tembisa has his family in KZN. I just didn't get the exact location where in KZN, but it's recorded as a patient who was in Ekurhuleni in Tembisa because of work, but with a primary family being in KZN, but he had not been back to KZN since December. Looks like he was last there during the Christmas holidays. Now, the patient who demised in Pietermaritzburg has confirmed primary residence in Ekurhuleni. You see now, very interesting. The one who demised in Ekurhuleni is primarily from KZN. The one who demised in Pietermaritzburg in KZN, primarily from Ekurhuleni in Brakpan. So it's the 2. All that it reflects is there are the 2 epicenters, KZN and also in Gauteng.
All these have no history of travel, which you're saying is an indication of local transmission. Does that mean we are sitting on a high number of cases than just these 6?
It suggests so. So that's why we really have to very thoroughly follow up on the contact tracing. It's quite complicated. Our teams, both in the 2 provinces, are doing the best they can. You would have seen from our report this morning that there's been some good progress in some cases where a number of family members, in terms of family, and also, of course, because as we have explained that unlike the COVID and others, respiratory diseases which spread through the air in terms of aerosol spread, this one is through direct contact, physical contact. So amongst others, sexual contacts are also very important. So it's a little bit difficult. But our teams are in the 2 provinces. So in this particular case, the KZN team is already following up and also communicating with Gauteng, where the family of the recent one resides. So that's what we are doing, because it does suggest that actually it might be higher. At least with one of the KZN cases, according to the clinical reports, gave quite extensive information, which actually resulted in a confirmation that there was also some contact with the other 2 in terms of the previous, the earlier 3 cases in KZN. there was a finding that from the information from one of them indicating that he had actually had contact with the other two.
Yeah.
So it might be confined in a way, but there are others who there is no direct linkage.
So you speak of immune deficiencies. We were speaking of comorbidities during COVID. What is the fundamental difference there? Immune deficiencies, how would those be presenting themselves? Are people suffering particular diseases that their immune system would be compromised? I know HIV is one of them, which you have cited.
Yes, immune deficiency, the most dominant and why we are concerned in terms of the level of possible high fatality is because we do have a high prevalence of HIV and AIDS in South Africa. As already indicated, all 6, including this last one, confirmed to be also HIV positive. So that's one of the dominant drivers of immune deficiency, but also in terms of people who are on treatment for cancer, especially with chemotherapy, also does contribute to reduced immunity. Also, any other what we call debilitating disease, where people are not able to even feed properly because of serious debilitating diseases. It's largely more on the cancer side that this becomes so. Of course, advanced maybe a kidney disease also, somebody who's have chronic kidney disease, including failure, which needs dialysis, would also become immune compromised. So there are a few of those, and largely in the category. But it's also comorbidity only means that a person has a particular disease currently, but this disease, especially an infectious disease, happens when the person is already having a chronic disease. Now, in our country, of course, from chronic, we classify HIV also as a chronic disease, because now people with HIV live long, but there's got diabetes, kidney disease, high blood pressure, severe high blood pressure, heart failure, kidney failure. All those are risk factors in terms of a severe illness.
Let's talk treatment then. Others believe the disease resolves itself, so there's no real treatment for it. However, you could use the same kind of treatment drugs that you use for smallpox, which are antivirals. Is that what we are looking at?
Definitely. Ordinarily, especially in people who have strong immunity, it's really a disease which resolves itself over time. The body is able to fight it. But when the disease becomes severe, then we have to use antiviral treatment, and which is the case in this case. All those patients, we had already acquired the antiviral treatment, but I don't think this last report from the hospital in Pietermaritzburg had been started on antivirals, because they only confirmed the diagnosis, it looks like hours after the patient had actually demised. There was a long delay, as I've said, which we want to find out. But the one who demised in Tembisa, because part of the skin eruption also can be also in the mouth. So that patient, from the report which we got, could not even, swallow properly. So they struggled also to feed the patient with the antiviral because of the severity. But ordinarily, we had already acquired, our teams had already acquired the antiviral treatment.
So the antiviral treatment is now here, because I was reading somewhere they're saying there are some 10 doses that are waiting somewhere in the UK, if I'm correct, waiting for some paperwork.
No, that the emergency supply had already been acquired. Our SAPRA, Medicine Regulatory Authority, had given permission, so the emergency treatment had already arrived in small doses. So what our department, our pharmaceutical section, is doing now, working under SAPRA, is to work with the WHO to get more doses, in anticipation that we may have more patients. So that's what is waiting, more doses to come over. But for the patients who had already been diagnosed, the doses had already arrived.
So that question of availability, I believe we don't have registered drugs here in the country at this particular point. Any reason why? I mean, we saw an outbreak, however be it small. I mean, there were cases, let me not say an outbreak, reported in 2022. So we are seeing more of them. Is there a conversation around having that drug registered in the country?
Well, the procedure for registration is quite a complex situation. That's why we rely on emergency approval, because government, in terms of our medicines regulatory system, the Department of Health cannot on its own acquire registration of a medicine, except in this case in terms of emergency. So because the system is such that the companies the pharmaceutical companies who are the ones who trade in medicine apply to SAPRA for registration of a medication, which, if whether you are producing it locally, it must have been registered. If you want to bring it into the country, you must also have the documentation to have it registered, and then it becomes registered. There are certain requirements for it to be registered and then be available in the country. Now, because of that regulatory framework, and because being not an endemic country and in very small doses of requirement, that complicates the situation because pharmaceutical business is a business. So if you have a very low consumption or an uptake of a particular product, your retailers, your pharmacy retailers, or the big ones, there is no real appetite to actually put in an application to the regulator so that it can be stocked in the country. So we're going to rely on this until maybe we just hope. Look, we are not hoping that we should have more cases. We'd like to have a few cases, if not zero.
Yeah.
So that complicates things in terms of any of the pharmaceutical businesses getting the appetite to actually put in an application with SAPRA for the medicine to be stocked in the country.
I know it's a horrible word for some because of the COVID-19 experience, but vaccinations is another conversation that needs to be had. Smallpox vaccines, which apparently also work for monkeypox, were stopped in the 80s. Why? And what is the rationale of not continuing with that program?
Again, because of the low demand, that's why the vaccine was stopped. But there are a number of combinations now which are being improved, which are derived basically from that smallpox vaccination, because it's sort of in the same family. They are being improved, and we are also working with the WHO to acquire now, because of the fact that Mpox is endemic and quite prevalent in some countries. Those countries do have stockpile of vaccines. So we're working with the WHO to acquire those vaccines, which are, of course, derived from the same formula as the smallpox, but I think they've done some work to adjust them to be much more potent in terms of those at high risk of Mpox itself.
So you've called for cooperation with the outbreak response teams. What does that actually look like? What will they be doing? Do they generally go across the country, or do they go to places where they believe there could have been exposure?
Well, we have outbreak response teams at national and also in each province. So at the national level, we have within the national department, we have also with the NICD and also laboratories working also in partnership, both public and private, the NHLS and also private laboratories. So whenever there's something like this, we activate the outbreak response team at national level, but also at provincial. So Gauteng and KZN will activate their outbreak, whether it's measles, whether it's cholera. So in this case for Mpox. So they will do the surveillance, the contact tracing, and the reporting in terms of any other risks to make sure that we can be able to respond to the challenge of this nature.
And what does that response entail? Is the quarantining that's required, limiting of movement to contain the spread, and so on and so forth?
Definitely. So because in this case, I mean, as you know, one of the patients who had been in hospital has been released for self-quarantine with supervision, and then the other two are still in hospital. So those are the kind of steps which our outbreak response teams will be monitoring. Those who are still in hospital, of course, will be isolated in hospital. But once the symptoms have subsided and the patients, and they have checked also the home environment, the patient can then be released once they are very stable. But for a certain period, they need to be quarantined, and then our outbreak response teams will have to monitor that, because just in terms of following all those steps, we can be able, hopefully, to make sure that it can be contained, not to spread any further.
What's the broad safety precaution, I suppose, that general South Africans should be taking towards this outbreak?
Well, the broad precaution is really to say that we know that this disease is in the country. There's a local transmission. I mean, there's always a risk in terms of the risk factors but these are things which are also documented. So we do need to say in terms of hierarchy, the pattern, not only in South Africa, but also in other parts of the world. And as to the rationale as to how it became like that, for instance, that's far, both in 2022 and also now, it's male patients in the sort of middle age, and even though generally the spread is said to be a close contact, what has become predominant is also that it looks like more in terms of the sexual contact, but also the fact that it's predominantly, not only here, but in other parts of the world, also related to men who have sex with other men. So that's a high risk in terms of also sex workers will be at high risk. But also, but what we would then say is that anybody, because it can't, anybody who has close contact, it can actually be can be infected. So the sensitivity, I mean, what we would want people to be cautious of is if you have any indication of a skin rash, which is progressing, getting worse, with fever, headaches, general viral fatigue, all those kind of things. But what is quite characteristic is the rash.
Yeah.
That people must not hesitate to seek medical attention.
Minister, we appreciate your time. Thanks so much for coming on. Minister of Health, Dr. Joe Phaahla there, joining us on the monkeypox outbreak. 2 fatalities, 2 deaths now reported, and 6 cases, it seems, 4 of them in KwaZulu-Natal. The 6th one saying it came immediately, an hour and a half after the announcement. It seems to have been coming from the Pietermaritzburg area there.